All right, let's talk about diabetes. So real quick, just to dust off the patho and review for a second, we got two types of diabetes. Type 1 is where we have our absolute insulin deficiency. Type 2 is where we don't have enough or we have resistance to insulin that is naturally produced. So to restate that in kind of my words, type 1, you can't make it. Type 2, you can't use it if you do make it. So those are our big two patho considerations that we need to think about when talking about diabetes. When we talk about presentation of diabetes, there's a lot of similarities because our problem is more or less the same, but the etiology of the problem is different. So some of the big things we're looking for are all those polys or the Ps. So polyuria, polydipsia, polyphagia are common regardless of the type of diabetes that we're dealing with. And here's some of the cartoons in case you guys are decorating your walls with some of these lovely nursing cartoons that I've been throwing at you this term. So assessment. First thing we need to be assessing for or looking at is our recognition of cues. First thing we can look at is our lab work. So blood glucose levels. And just to review, our normal levels are 60 to 100. Hyperglycemia is on the high side of that. So 100 to about 300 is our kind of yellow zone where it's like, okay, well, that's abnormal. 300 to 400 is our orange zone where it's like, oh, you have my attention. And greater than 400 is where it's like, okay, this is bad. I need to drop what I'm doing and go address this. So we've got a really big range on our hyperglycemic side. On the hypoglycemic side, we have a much, much tighter range. So when we're talking about lab values like 50 to 60, we don't even have a yellow zone. This goes straight to orange. So it's like, oh, this is bad. And then less than 50 is I am dropping what I'm doing and going to address this. So recognizing cues, looking at the body systems that are most important to pay attention to. First, I mean, there's not one place to look. It's really the whole body. There's a lot of different symptom presentations associated with diabetes. Some of the main symptoms we want to focus in on are neuro, cardiovascular, renal, skin, and musculoskeletal. So looking at analysis of cues for those body systems. For our neuro, we're really looking at things like vision changes, which can include blurring and blindness as that progresses. Altered mental status, and this has to do a lot with the hypo versus hyperglycemic presentation. For hypoglycemic, which is by far our most concerning side of the spectrum, patients kind of have fatigue, and they kind of act like your drunk friend at the end of the night when they're kind of tired but still flopping around like an altered person. That's really our hypoglycemic presentation. On the hyper side, we're talking about like mental status irritability, which is really like dialing up the neurologic kind of function. So it can present like a manic person. So think of this as like the early in the night person who's friend of yours who's drinking too much when they want to go to all the parties and do all the things. That's really our hyperglycemic presentation. And then our final thing that we need to focus in on for neuro is our neuropathic pain. There is a strong correlation with nerve damage with uncontrolled diabetes. So we want to assess the nerve damage in the distal extremities and neuropathic pain as part of our diabetes assessment. For cardiovascular, one of the big risks and things we want to look out for are symptoms of heart attack, so chest pain, unstable blood pressures, and that's because of the angiopathy that's associated with like atherosclerosis, so the hardening of the coronary arteries. Reason behind that is sugar crystals in circulation kind of drag against vascular walls, causing scarring to occur, which decreases the elasticity. So that's what causes the hardening, is that scarring. Next one, looking at the kidneys, our renal system, acute renal failure leading to chronic renal failure. So uncontrolled diabetes is our third leading cause of end-stage renal disease requiring dialysis in patients. And the reason is that same kind of problem as with angiopathy is that crystal in circulation damages kind of the microvasculature, the capillary beds where filtration happens in the kidneys, which damages their ability to filter. So early symptoms of kind of acute renal failure, we're looking at things like polyuria or polydipsia. So producing a lot of urine because the kidneys aren't filtering, they're just dumping everything. Later on, when we move into like chronic renal failure, then we're looking at symptoms like anuria. So the kidneys aren't making any urine anymore. So that's kind of our progression for renal. For skin, there is a big risk for diabetic ulcers, which tend to occur on the feet or lower extremities. These wounds are very slow to heal because of alterations in blood sugar availability to healing tissues. And there's also a high risk for infection, especially with patients who lean more towards the hyperglycemic end of the spectrum because it's a warm, dark, wet, and sugary environment. So bacteria love to grow in there. And musculoskeletal, we talked about mentioned mobility a little bit. These wounds, if we're not able to heal them, this could require a surgical intervention, such as amputation, that can really limit a patient's mobility long-term. So when you think of hypoglycemia versus hyperglycemia, when you think of hyperglycemia, think hot, because diaphoresis is common with both hypo and hyper, but think hot, so patients are going to be warm and wet, whereas hypoglycemia, patients are going to be cold and wet. So cool and clammy kind of presentation. So prioritizing hypotheses. On the medical side, to achieve diagnosis, we do a few different types of testing and data gathering. For screening, family history is really important because we do see genetic components or genetic links between diabetic patients, and also symptom presentation because there's a strong kind of correlation between patients showing up either hypoglycemic or hyperglycemic. Nobody ever comes to a doctor thinking like, oh, I'm diabetic, I have no symptoms. Usually the symptoms they're presenting with or the reason they're seeing a doctor is because they're either hypo or hyperglycemic and they have symptoms of those dysfunctions. Other reason is urine output. All of a sudden they're producing a ton of urine and they don't know why. So that can be a trigger for us to start screening them for diabetes. One of the tests they may be asked to do is a fasting blood glucose. This is where they're kind of NPO after midnight, and we check their blood sugar first thing in the morning before they've had anything to eat. And that value is very helpful for physicians in determining risk for diabetes. Imaging, we don't have any imaging for diabetes, but we do have sampling. So we're going to collect blood samples. Specifically, the test we're going to do is a hemoglobin A1C. And this is kind of a gold standard for diagnosis. What this test tells us is like a 3 to 4 month average blood sugar that the patient has had. So we can correlate this directly with how hyperglycemic somebody has been over a long period of time. The table over to the left shows us how we do that correlation. So for non-diabetic individuals, an A1 or very well-controlled diabetic individuals, a A1C level of between 4 and 5 is considered good control, good diabetic control. Between 5.5 and 7, these are elevated blood sugar levels. So these are concerning. Some of our pre-diabetics might be in this range. Greater than 7.5 is elevated blood sugars over a prolonged period of time. These are patients who are at very high risk for being diagnosed with diabetes. So we can see here, the way to read this is if a patient has, say, a A1C of 7.5, that means their 3-month average blood sugar is 187. So that would be very concerning for diabetes. On the nursing side, we've got some actual nursing diagnoses that are very applicable to diabetic patients. Things like knowledge deficit around all the manifestations of diabetes, what diabetes means, what a hemoglobin A1C is, what are symptoms of hypo and hyperglycemia. There are so many knowledge deficit components to diabetes. There's a lot of teaching that we do in the outpatient and inpatient setting for diabetes. And then chronic pain is another one, especially if they're having neuropathic pain in their extremities. On the risk management side, big risk for unstable blood glucose levels. This is kind of the definition of diabetes. So it's a big risk for anybody with diabetes. Risk for infection, we talked about that in relation to wound care, and risk for impaired mobility around those wounds as well. And a key thing to remember here is that presentation, especially of neuro symptoms, things like the vision changes or neuropathy, can be more pronounced or kind of worse presentation as patients get older. So they can be have a little less resilience as we age, meaning those symptom presentations are going to be much more uncomfortable. For generating solutions, so things we want to prioritize when we plan care for these patients, lifestyle changes are a big part of diabetic management, because the earlier we can start lifestyle modifications, the more we can prevent the escalation to full diagnosis of diabetes and greater interventions for pharmaceuticals and testing, like monitoring of blood sugars. So we want to start these lifestyle changes when patients are pre-diabetic if possible. Diet modification includes a diabetic diet, which is like low sugar, low carbohydrate diets. And then exercise. Moderate exercise, especially cardiovascular exercise, not so much like getting shredded and swole up at the gym, has a very powerful effect on blood sugar. I can lower blood sugar by a significant amount by just including regular cardiovascular exercise in a patient's plan of care. But we always want to, when we consider implementing exercise, we always want to meet patients where they are. It does no good to tell a patient to go ride a bicycle for 20 minutes 3 times a week if they have a wound on their foot. That's not realistic. So we need to figure out like what kind of activity are they capable of doing and how can we use that type of activity to meet our activity goals for this patient. On the medical side, management is really complicated. So the big thing we need to do is glucose management. So checking their blood sugars. We talked about hemoglobin A1C as that 2 to 3 up to 4 month average of their blood sugars, which is part of our screening. It also, as an outpatient, lets us know how the patient has been managing their diabetes independently. But what we do in the hospital setting is point of care testing or POC testing. This is the bedside glucometer testing. So we can check those either AC, PC, or HS. AC meaning before meals, PC is after meals, and HS is hour of sleep. For newly diagnosed diabetics or patients who are being started on a new medication regimen, we may be checking before meals and after meals, so AC, PC, and HS. For patients who have been diabetic or who are stable on therapy, ACHS is kind of the main frequency that we're checking blood sugars on patients. And then also assessing for hypoglycemia and hyperglycemia. Hypoglycemia, we're going to talk a lot more about here in a little bit. But hyperglycemia, some of the things that we need to consider on the medical side are what's causing it. So these can be things like stress, physical stress. So a lot of diabetic patients who are coming into hospital with other infections or other medical disorders may have altered blood sugars because of their underlying or because of their acute disease. Also, emotional stress can release cortisol in the body, which is glucose-based or glycogen-based, which can elevate blood sugars as well. So we do want to assess stress in patients as a cause for hyperglycemia. And then there's this category of kind of ways we manage hyperglycemia called sick day rules. What this is if patients have an infection or an illness that's acutely exacerbating, this can cause alterations in their blood sugar towards hyperglycemia. So what we want to do is more frequent assessments of their blood sugars and also possibly more frequent interventions for their blood sugars. So patients who normally just check their blood sugar once a day, if they're hospitalized, we may be checking their blood sugar ACHS. So we're going to check their blood sugar more frequently because of their illness. This may also lead to more frequent dosing of insulin because of more frequent monitoring of blood sugar. And that's because we have capability of doing that in a hospital. And we know that because of underlying illness, there's a greater risk of uncontrolled blood sugars. For worst case scenarios that we should always keep in the back of our mind for any diabetic patients, in the short term, we've got problems of low blood sugar, so hypoglycemia And again, looking at our blood glucose levels, it's a very narrow range of glucose levels before we start getting very concerned about hypoglycemia. And on the hyperglycemic side, we have things like DKA, diabetic ketoacidosis, which is most common with type 1s, and HHNS, HHS. There's a lot of different abbreviations for the same hyperosmolar hyperglycemic syndrome, which is most common with our type 2 diabetics. In the long term, the worst case scenarios are the pathies that we need to look out for. So retinopathy, nephropathy, neuropathy, and angiopathy are the big complications of uncontrolled diabetes long term. So when things are going good, we can control a person's diabetes. And by control, I mean like keep their blood sugars close to a normal range through exercise, which increases cellular uptake of glucose, meaning there's less free glucose in circulation, so their blood glucose level is decreased, which is good. We can do diabetic diet, so there's less glucose in circulation. And diet modification is a really powerful independent intervention we can do with patients. Because if they're pre-diabetic and they can control their diet, their sugar intake and carbohydrate intake, they may not require medication management. They may not require insulin to control their diabetes. And then what kind of medications we can give. So pharmaceutical agents are the other kind of good intervention that we can do for diabetic patients. So they can help keep their blood sugar in that good range. And the main medication we use is insulin for diabetic patients. For some patients, when we talk about ways to give insulin, when things are going well, they can use either an insulin pump, which is most common for our type 1 diabetics. And these pumps are really cool devices that terrify hospital-based nurses because we don't know how to use them and they freak us out. So what the pumps do is they both monitor a patient's blood sugar. So they're continually monitoring what the blood sugar level is. And they can also deliver a dose of insulin based on hyperglycemia. They also have built-in alarms. So they will notify a patient if they're becoming hypoglycemic or extremely hyperglycemic. So they can intervene to correct their blood sugars quickly. For insulin injections, we tend to use a sliding scale to deliver insulin. So there's an example in the graph down here of how many units of insulin we would give for a certain blood sugar range. So if our patient's blood sugar was say 225, we would go down to the third row where the range is 201 to 250 and give 5 units of insulin through subcutaneous injection for that blood sugar. The sliding scales are all different based on facility, based on physician, and based on patient. So don't take these numbers as kind of this is what a sliding scale is. The number of units of insulin delivered for each blood glucose range will vary patient by patient. So do keep an eye out for those variations. Some things that we should consider when patients are getting insulin injections is always rotate the sites regularly. If patients inject insulin into the same place time and time and time and time again, that can develop scar tissue underneath the skin, which can decrease absorption. On the flip side of that, where we have increased absorption, is if patients are going to exercise quite a bit, then we want to avoid injection around that muscle group because that'll cause an increase in absorption subcutaneously. So as an example, one of our injection sites is say like the tops of the legs, so the thighs. We wouldn't want to inject insulin in the thighs if a patient is planning to go for a long hike or something like that, because that increased activity will increase the rate of insulin absorption. So real quick, just when we talk about insulin types, looking at this kind of body picture of the sites that we can use, a couple clarification points. So we talked about the thighs being a site, the abdomen is a well-known site, and the shoulders. So this is kind of highlighting the deltoid, but the deltoid isn't a subcutaneous injection site, but the tricep is. And it's a site that a lot of hospitalized patients prefer because it's not terribly innervated. So it's not as painful to get injections there. But we can use the back of the arms as well, but not the deltoids. For the types of insulin, you guys learned quite a bit about the types of insulin in patho. So we're not going to get into that. The important things to note are some of the differences between them. So onset times, durations, how they all vary and how they're all stratified by how long each one lasts, and then the special rules that apply to them. So things like short-acting insulin or regular insulin is the only type of insulin that can be given IV. And we're going to talk more about that when we talk about some of our hyperglycemia dysfunctions. And also like glargine or long-acting insulin is the only type of, like you never mix that type of insulin because the effect is so long. We never mix glargine. And anytime we're giving insulin to a patient, we want to be aware of the Somogyi effect, which is, it's that rebound hyperglycemia at night, more specifically like early morning hours of the night. So the early AM hours. And what that is like, it's been so long since patients have eaten, their insulin injection is starting to lower their blood sugar levels. So we want to watch out for that type of effect in patients, especially patients with a change in dose of their insulin. Here's a graph that kind of shows the different types of insulin and the coverage they provide over time. So on the x-axis, we have number of hours. On the y-axis is the relative power or effect of the insulin that we give based on coverage. Just to give you an idea of like how we provide 24-hour insulin coverage to lower a patient's blood sugars for the course of a whole day. So the bad. Let's get into the bad things that can happen to diabetes. So first one, and most important, is hypoglycemia. Recognizing the symptoms of hypoglycemia, like they're illustrated here, is super important because we always need to collect those 3 pieces of evidence, and a low blood sugar level is only 1 piece of evidence. The reason we need to recognize hypoglycemia so effectively and quickly is that this is what kills people. People die of hypoglycemia way more frequently and way more readily than they do of hyperglycemia. So we always need to be comfortable with assessing this. If you assess hypoglycemia in a patient, the immediate action we need to take is figure out how neurologically intact they are. And what I mean by that is how well can they follow directions, because that will guide what intervention we can do next. Because our interventions always want to go from least invasive to most invasive. Our least invasive way of managing hypoglycemia is to give people PO intake. So things like juices. This is why apple juice and orange juice, those kinds of juices, are always stocked on a nursing unit in the kind of kitchen area. Those juices are simple sugars that can be quickly absorbed and correct a patient from hypoglycemia that could turn into a dangerous problem. The risk with just giving juice is that it wears off very quickly. Those simple sugars are used right away, and then there's no more left. So we always want to follow up those juices with some more complex carbohydrates. Some like graham crackers are a great example of like a sugary carbohydrate that can keep a patient's blood sugar elevated for a prolonged period of time compared to just drinking juice. In the outpatient setting, patients are usually advised to keep like hard candy on them because that'll deliver sugar over a period of time that can kind of be a rescue method for when they experience hypoglycemia. If patients are not able to follow directions, so they're not able to drink fluids or eat graham crackers, then we need to rescue them by giving them medication through their IV. And the medication we give is D50, so 50% dextrose in an injection. And it comes in like a 50 or 60 cc syringe. It's a huge syringe, and you hook that up to their IV and you push it. And you push it with 2 hands because this stuff is like pushing syrup through an IV. It is really thick. It is really hard to push. So these are emergent interventions. So as soon as we do this, we need to be calling a physician, letting them know that the patient has had a hypoglycemic episode and what we did about it. So next on the bad side is hyperglycemic. So again, we don't get super concerned until it's way high, like greater than 400. But the longer a patient is hyperglycemic, the more they're at risk for some of those long-term complications of diabetes, things like all the pathies, retinopathy, neuropathy, nephropathy, all those kinds of complications. Our main way of managing hyperglycemia is insulin. Rapid acting is our go-to insulin for mealtime coverage. So when we check a patient's blood sugar on their finger, we want to give rapid acting insulin to cover that blood sugar. Long-acting insulin is meant to cover a baseline blood glucose elevation over the course of a full day. So A1C testing is more helpful for dosing long-acting insulin, whereas point-of-care testing is more helpful for dosing rapid-acting insulin. So we may need to balance long and short-acting insulin in order to adequately cover a patient's blood glucose levels over the course of 24 hours. Super important also, whenever we're giving insulin, we always want to assess for overdose of insulin, meaning that we're giving too much, which would cause hypoglycemia. So that's always something that we want to assess for. I got a frog in my throat. Hang on 1 second. Okay, I think I've cleared that out. So next, when it gets ugly, then we get into our hyperglycemic emergencies. First one we want to talk about is DKA, which is diabetic ketoacidosis. So this comes about because there's an insulin deficit, which leads to hyperglycemia, which causes fat metabolism, which releases ketones into circulation. The main ways that, or the actions that we take, the main interventions that we look for DKA is threefold. So the first thing we do is hydration, IV fluid hydration, because the solution to pollution is dilution. And in this case, the pollution is blood glucose. So we want to dilute their blood glucose back to a safer level. So we'll lower their blood sugar by just diluting it in circulation. We are also going to lower their blood sugar by giving IV insulin, because this addresses the actual problem, which is too much blood sugar in circulation. We can't just volume overload people to fix this problem. We need to actually bind the glucose in circulation and get rid of it. The other thing that happens is when we give IV insulin, that forces intravascular potassium into the cells. So it causes a shift of potassium out of circulation, which makes patients hypokalemic. And anytime you start thinking potassium dysfunction, you start thinking heart problems. So anytime the patient is in DKA and we're intervening by giving IV insulin, we always want to put them on a cardiac monitor just to keep an eye out for some of those cardiac dysrhythmias associated with hypokalemia. The other ugly here is HHS, or that hyperosmolar hyperglycemic syndrome, which is most common with our type 2 diabetics. So this is where osmotic pressure, because of hyperglycemia, causes severe intravascular dehydration. So fluid is forced out of circulation into the cells, meaning patients can be hypovolemic in circulation. So our intervention here is to fix the hypovolemia caused by osmotic pressure distribution. But it's okay to think of this as just severe dehydration from blood glucose. We are going to give many, many liters of IV fluids via fluid bolus, meaning as fast as they can go in. In order to achieve that, we need to make sure we have a reliable way to infuse all that fluid so quickly. So large bore IVs are our go-to intervention here. We want to make sure they have at least one 18 gauge IV, but the more they have, the happier we will be as nurses. So 1 is good, 2 is better, 3 is best, but 3 can be also a little awkward for patients. So 1 is good, 2 is better. Electrolyte alterations are also going to be associated with this osmotic pressure shift of fluid and all the IV fluid that we're going to give patients. So patients tend to get very hypo in their electrolytes. So hypokalemic, hypophosphatemic, hyponatremic are all very, very important. So we do monitor and replace these electrolytes as part of the treatment of HHS. And the reason we monitor these three is that these are the three that are going to kill patients the quickest. Heart and phosphorus, this is the heart. Sodium is the brain. So we don't want any of those things to stop working because then patients will die. So replacement of those electrolytes may be a part of our diabetes management. Finally, our last ugly solution for diabetes is amputations. So we talked about these diabetic wounds, and here's a picture of one. And these can be really hard to heal because this hyperglycemic environment inside the body is an outstanding place for bacteria to set up shop and live forever. If that happens, it's very difficult to treat these wounds because of they're open for so long. The big reason that patients end up needing amputation is because that wound can become infected for such a prolonged period of time that infection can move into the bone underneath that wound. And we call that osteomyelitis. Osteomyelitis is extremely difficult to treat because bones are very, very poorly vascularized. So getting IV antibiotics into a bone is extremely challenging. Oftentimes, that only leaves us one solution, which is to cut the infection out. And that's where we get all these various levels of amputation that patients may go through. As you can see for this foot, there's 7 different levels all below the ankle that we can amputate a patient's foot. And then we've got many more levels above the level of the ankle that can be amputated based on where the osteomyelitis has progressed to. But that's the main reason patients get amputated is because of the osteomyelitis. So for evaluation of diabetes, disease management is really important, and we're going to achieve this through diet modification and glycemic control. So we always want to make sure our patients have an effective way of doing these things. So for diet modification, teaching is a big thing. Same with glycemic control. All of these topics of evaluation, we want to evaluate our teaching of these topics, and anytime possible, we want patients to return demonstration on particular skills. Some of the other teaching topics that we really want to prioritize are symptom management, and especially recognizing when they're in trouble. Patients get in trouble when they are hypoglycemic or hyperglycemic. So us knowing the symptoms so that we can teach those to patients, really, really important. And also what to do if they get in big trouble. If they start having some of those ugly complications of hyperglycemia, that's when they need to go to the hospital. And also pain. Pain is a predictable side effect of diabetes or manifestation of diabetes, that neuropathic pain. So that's something that we want to teach patients how to manage and work with them to evaluate how effectively pain management is, because neuropathic pain can be very difficult to treat. And then preventing complications. The big way we do this is through blood sugar control, but we do want to help patients to recognize what complications they're at risk for so they can point those out to physicians as they come up. So vision changes, urine output are 2 big categories that patients can let us know if they're starting to experience. The other big one is wound assessment. If they're developing wounds on their feet or legs, we want to make sure they're assessing those parts of their body regularly, especially their feet. Because of the neuropathy associated with diabetes, there's a high risk of foot injury without feeling the injury. So we want to make sure patients can assess their feet and use any adaptive equipment necessary to really examine the soles of their feet, so the bottom surface of their feet, and all the sides of their feet, just to make sure there aren't any wounds developing. Because if those get really bad, that may require amputation in order to heal. For those of you guys that like concept maps, here's a concept map covering all the stuff we've talked about with diabetes. You can feel free to print it out, stick it on your wall, decorate your home with lovely nursing things. The only thing we didn't talk about here is gestational diabetes, because I don't do babies or any of that. I don't do little people or the people they come out of, because that's all like that. not my thing. So what just happened? Diabetes is super complicated. The symptoms are going to affect patients in every body system. So recognizing the symptoms and the complications, especially around hypo and hyperglycemia, really important. Insulin therapy is the most prevalent treatment that we offer for blood glucose control. And this requires frequent checking of blood sugar and frequent dosing of insulin in order to correct their blood sugar. So we want to make sure patients are competent with that equipment before we send them out to manage their diabetes. And then the complications of kind of hyper and hypoglycemia, they're pretty severe. So we want to make sure patients are able to recognize those symptoms and what actions they should take should they experience them, especially hypoglycemia, because this is the one that kills people. They need to recognize it as early as possible and act on it early to help save their life. For example, if patients are going in DKA, they should call 911 because that's a medical emergency that they are going to need help to manage. We need to do IV therapies to manage that. But if they're hypoglycemic, the first thing they should do is eat or drink something. Then see if they can rescue themselves. If they can't rescue themselves, then they should call 911. POC testing, so glucometer testing, is our #1 tool for identifying all the bad things that happen to patients when they're diabetic. So that is really what we want to make sure they're able to do, is to check their blood sugar, because that's a great piece of evidence to let us know how well they're managing their diabetes. That's it for diabetes, guys.